Yes, perfect. Okay, so we're going to be talking about heme emergencies, like I mentioned, and this I can just read the case myself, so we can save a little bit of time. But let's say you admitted a patient while rotating in the lymphoma service at MSK. It's a 41-year-old male with past medical history of HIV who's on antiretrovirals and has normal CD4 and negative viral load. And this patient is being evaluated for rapidly enlarging lymph nodes. And then on exam, you have a right supraclavicular and right axillary nodes that are enlarged, fixed, and indurated. Alarming, as you can see. Of course, you're already biased by the center that you're working at, right? And then the biopsy is performed, and this patient is found to be positive for Burkitt's lymphoma. CT chest, abdomen, pelvis shows splenomegaly as well as mesenteric and retroperitoneal lymphadenopathy. This patient is scheduled to begin treatment with EPOC or EPOC, whatever you want to call it, this week. So which condition or heme emergency are you worried that this patient might develop, and why? So I see Nobel is saying tumor lysis syndrome. Same with Dio. That is correct. And Galita also said it. Now, to the second part of this question, why?
High burden disease.
Exactly. So you have some things that are telling you that this is a patient that has a risk for like high tumor burden, which we'll go into a little bit. Burkitt's lymphoma is one of the ones that's classically, correlated with TLS, and you also with immunodeficiency, specifically HIV. And then you have the CT abdomen pelvis that is showing extensive like lymphadenopathy and splenomegaly, just organ involvement. And one more thing, can anyone tell me like what I'm missing here that's also predisposing this patient to have TLS? Oh, sorry, I just saw Nobel actually put it. So he's and Dio as well. So yes, exactly. When you're about to start aggressive chemotherapy, you're gonna be worried about the tumor lysis, right? Which is in the name. And we're gonna go a little bit more in depth into this. But now with newer therapies that are more effective and can cause faster tumor shrinkage, this is something that can be concerning in some tumors that weren't normally associated with tumor lysis syndrome. So why is tumor lysis syndrome important? Basically, this is a potentially life-threatening emergency and develops, as we said, after the lysis of malignant tumor cells. And it results from the inability of your own body to respond to the rapid release of intracellular contents. I'm gonna go into the next slide, which explains some of it. I'm only sharing half of it right now because I just want you to focus on this top part. And basically, like we said, you have a huge lysis of cancer cells. So both aggressive chemotherapy that causes fast destruction and a tumor that rapidly proliferates and has a high tumor burden will predispose you to have TLS. And the reason why is you have, like we said, the spillage of intracellular contents. You have release of DNA, which later, will affect the uric acid production, but you also have, electrolyte imbalance, phosphate, you have potassium. And you also have a release of intracellular cytokines that can cause hypotension, inflammation, and maybe even cytokine release syndrome. So all of these are important, and I just wanted to go a little bit about the pathophysiology, and we'll talk a little bit more about the rest later on. So some of the risk factors for tumor lysis syndrome are renal dysfunction, high baseline hyperuricemia, hypotension, and this is partially because poor renal perfusion is going to affect your clearance. And like we said, high tumor burden, it's particularly associated with, like we mentioned, Burkitt's is the classical ones, but also other tumors that have high cellular proliferation, like ALL, AML, multiple myeloma, and then you also have some solids that are solid tumors that are associated with it. So mostly the ones that have high tumor burden, like small cell lung cancer, melanoma, then sometimes of breast cancer and germ cell tumors can have that as well. And I forgot to mention, but I guess it goes part of the tumor burden, but organ involvement specifically as well, metastasis to the liver, also increases your risk of developing TLS. Tumor response to treatment, again, if for example, this patient with very high tumor burden, sometimes you'll see it at MSK, that has a lymphoma, and you're giving steroids plus a ton of other like chemotherapy agents that the tumor is very sensitive to, you'll have higher risk. And of course, you have to like hypovolemia and urine acidity also affect the risk factor of TLS. And so, yes, why is it important? It can lead to organ failure and death, and it's something that is, potentially preventable once you identify it. So, like we saw with this patient, if you identify it early on, you can take measures to mitigate the risk. And like I said before, novel therapies with enhanced cytotoxicity can increase TLS and malignancies, whereas it would not have commonly been seen before. And so I'm not going to read the case again, but this is the same one. And so this patient presents like this at MSK, which are some of the labs that you would order prior to starting chemotherapy. And this is after talking a little bit about the pathophysiology as well. So I see the chat, give me 1 second. So Emily is saying G6PD. That's like 2 steps ahead, but that's great. I see Galit is saying BMP, LDH, uric acid. Nadim is saying electrolytes, uric acid, and I think you meant LDH. So why would you order all those things? So Emily, why are you thinking about ordering G6PD?
I guess I jumped ahead because we were talking about tumor lysis syndrome, but like Rasbira case, you want to make sure that they're at higher risk for hemolysis if they do have G6PD, which would be life-threatening.
I think you didn't jump ahead that much because, if this patient is presenting to you like this and you already have like a very high risk of developing TLS, it's good to think ahead and getting that even beforehand. But yes, Rasbira case, and we'll talk about it a little bit more later on. So the other ones, Galit, why would you want to see a BMP and LDH?
Well, because that's what you're going to trend, and the risk is hyperphosphatemia, hyperkalemia, and hyperuricemia. So, and also like the LD, if you have high tumor burden, then the LDH will be higher. So that would, make you think of that also.
Yes, perfect. So definitely BMP, like we just have to remember what is included and what isn't included. So I know Nadim and Raj mentioned uric acid, which is of course like super important. And so we have to add that. Then LDH, exactly, Galit. I think that's a very good surrogate for, tumor proliferation. So it's very much used for that, and it can also help even, guide you a little bit like treatment sometimes, and help you stratify the risk of this patient actually developing TLS. There are a few other electrolytes that, are not included in the BMP, and exactly, Raj, so FOS. FOS is a very important part of the pathology of TLS, and we should remember to add that. And so you send the lab work up before this patient starts chemotherapy for his Burkitt lymphoma. You see a creatinine of 1.7, baseline is 1, potassium of 5.9, FOS of 4.4, calcium 7.1. LDH is very high, 2,320. Here I give you the upper limit of normal of 100, and you see a uric acid of 13.3. So I see someone wrote in the chat, sorry. So calcium, yes, calcium is important as well, Nadim, and that's why I included it there. And I guess just right before we start with the question I mentioned is, Nadim, is calcium part of the regular, like, TLS labs, or like more than that, like why is calcium low? I guess it's my question, or what I'm trying to get to.
Isn't low because I don't know if it's like the phosphorus goes up, and so like as a compensation, I'm blanking a little bit. It's something with parathyroid, I think.
Yeah, I think you can think of it like very simplistically, like you have a higher release of phosphate because that's kind of like the basis of the whole disease, rapid release of intracellular components to the extracellular space. So you have a lot of phosphates that consumes a lot of calcium. And even though calcium is a part of the TLS labs, it's kind of like an indirect effect. And I want you to remember that, like, calcium, like phosphate, like precipitation, like later on. But going back to the question, how would you treat this patient before starting chemotherapy? And we're going to go a little bit over the therapy options as well later on. So Emily, hydration, perfect. I mean, that's definitely great. And why do we hydrate the patient?
Well, clearly the creatinine is already elevated, and so it's a protection for that. And like you were saying, the risk factors for tumor lysis syndrome being like hypotension is also associated with it. I don't know if there's other reasons.
So perfect. So you have already some organ involvement, and we're going to describe it a little bit further on. But yes, you have an increase in creatinine, which I guess in this case you would think could be from like the high tumor burden the patient is about to undergo, like the chemotherapy. And just a baseline, if this patient has a pre-renal AKI, even if it's not like TLS, this could like put the patient at higher risk of TLS. So you definitely want to hydrate them. You want to have a good urine output because all these components that I said are released from the intracellular to the extracellular space are excreted by the kidney, right? So you want to give the kidney a little bit of help in excreting all this excess intracellular content that is in that space, but also having that higher urine output can decrease the chances of some of these components precipitating and causing like further kidney injury. Like I said, there's also cytokine involvement in this pathology, meaning it also affects renal perfusion. It's not all crystallization that causes this effect, but definitely something important. What else would you consider about what else would you consider doing to see the chance? Sorry. When Nadim is saying decrease of uric acid stones, exactly what I was kind of like getting to when in terms of decreasing the risk of crystallization. And then solution to pollution is dilution. I like that, Lenise. And so Nadim, Keith K, and Foslo, lower risk of arrhythmia. Exactly. So now you're starting to think of like what is causing TLS, what is driving it, and why we want to do what we're doing, right? But then again, so Nadim, you mentioned decreased risk of uric acid stones. Would you do anything else to intervene? Allopurinol. Okay, why?
I think because you anticipate that when you start chemo, the uric acid level is going to go up even more. So you want to kind of decrease the production of uric acid in like anticipation of the chemotherapy.
So this is definitely a little bit more specialized. I hope you're not going to have to unilaterally make this decision while you're on the wards. But I mean, you see the LDH, it's 2,320, and you see the upper limit of normal is 100. So it's definitely like, over 20 times the upper limit of normal. And that would put this patient at very, very high risk. And not only that, but we have a uric acid that is already extremely high, right? 13.3. So I think that's a good thought. And it's kind of like what I wanted you guys to start thinking about. And right before we go into some of the therapy. But I do think there are other options, and something that we haven't mentioned yet right now that it's also extremely important. What haven't we done with this patient? Exactly, Raj. Very good. So you see the potassium is 5.9. I mean, how would we treat the hyperkalemia? So glaucoma, insulin. Emily is saying glaucoma, calcium gluconate. Okay, so we're gonna go a little bit more over the the treatment options later on. Definitely, Raj, I like that. Get an EKG, make sure that this patient is not actively having an arrhythmia secondary to hyperkalemia. You have calcium gluconide, which I would give, or like you can consider giving, for stabilization of the action potential, but you have to be careful with the calcium. We'll go a little bit more about it then, and it has to do with the what we already talked about, the hypocalcemia, right? Then glaucoma, it's not generally recommended when you're talking about tumor lysis syndrome, because not only does it have like the very, very, very rare side effects that are a little bit more likely in the onc population, but it also takes a few days to take into effect. So insulin, I would definitely like consider giving. Another thing is like you're kind of already treating it with hydration, right? Once you get that urine output up, it's gonna help a little bit. And what else can give, can keep the urine output up? Like what else would help you with that? That also helps with hyperkalemia. So Raj is saying Lasix, excellent. So yes, so we'll get into it a little bit later on, but once you start hydrating, you kind of go by the urine output. Like you do have to graciously hydrate, but you have to make sure that the patient is actually having a high urine output. So this is one of those few cases, where you can hydrate and give Lasix at the same time. No one should make fun of you for that. Like here you would have reasons to do so. And so now I'm unveiling the second half of the image I showed earlier on. And we talked a little bit about the causes of acute kidney injury. Some of it is cytokines, hypertension, inflammation, also the, precipitation. And here is where our uric acid agents are going to act. If you see here in section D, this is a figure that I took, by the way, from a New England Journal of Medicine review article. And basically, once you have the release of DNA, it eventually gets broken down into xanthine, and that gets broken down into uric acid, and then you can have crystallization of the uric acid. And this is kind of what I was alluding to before, whereas like, what would you give this patient that has a uric acid of 13 and like an extremely high LDH? Mention allopurinol, Nadim. So with this figure, can you tell me what allopurinol is and what it would do to the uric acid?
So it's a xanthine oxidase inhibitor, and
Yeah.
it would decrease the production of uric acid
Mm-hmm.
from like the hypoxanthine. So if you're anticipating that the tumor cells are going to lyse and release their DNA and those products into the blood, you want to decrease the conversion of like some of those products into uric acid.
Exactly, and I think that's an extremely good thought, and you'll see a lot of patients that might be, and have a low or intermediate risk of TLS be on allopurinol, because it prevents the formation of uric acid. You also have then an accumulation of xanthine, which is also can also crystallize. So and basically what I'm trying to get at is like in this patient where you have already a uric acid of 13 and you're preventing new formation of uric acid, but are doing nothing to like allopurinol does not bring it down, the level of uric acid that is already inside the patient. Like it does not help the patient get rid of that. It only helps prevent the production of newer uric acid. And so it takes a little bit longer to work. And in this patient that you already have a high creatinine, you are already worried about that precipitation, giving allopurinol, it's kind of like intervening a little bit too high up in this chain. And what other option would you consider that is here in the chart? Can anyone mention it?
Emily said, she's talking about.
Right. Yeah, Emily mentioned it before, exactly, and this is where it fits in. So it's rasburicase, and what rasburicase does, it's basically an enzyme that takes uric acid and breaks it down into allantoin, and that is a lot more soluble and you don't have to worry about that as much. It works out greatly. It has great effects, significant clinical impact. And in this case where, like I said, you already have a really high production of uric acid and you want to break it down and you're worried about end organ damage, I would say it is reasonable, even prophylactically, because if this patient has a uric acid of 13, an LDH of 2000 and something, even before you give chemotherapy, after you give chemotherapy, it's going to go up even higher, right? So there is this scenario and like where you basically end up using rasburicase prophylactically. Now, why is that a problem? Why is that a challenge? And why do we have to be very careful with how we use rasburicase if it works so well? Besides that G6PD that Emily already mentioned, that causes hemolytic anemia. I'm going to give you a hint. It's not a clinical reason.
Expensive, I think.
Exactly. So it is very expensive, and that's why we have to be very judicious in the way that we use it. But in this particular scenario, it would be considered warranted. Like I said, the uric acid level and the LDH, when it's higher than 2 times the upper limit of normal, you have to start considering using it. And especially in this case, that's Burkitt's lymphoma, classically associated with TLS. You might want to consider that. But most of the time at Sloan, because it's very expensive and because usually they don't come with an extreme presentation, like I said, usually they come more in the intermediate risk category. Most people are going to have allopurinol and hydration as a good pre-treatment regimen. Another thing that I forgot to mention that can sometimes be done is like you can give sort of, do you ever use provenecid? I mean, you can, but it's just not like as commonly used. I would say it's not as good as uric acid and allantoin, but I'll go over all the treatment options like a little bit later on. And what was I going to say? So yeah, so basically you can give in patients that have very, very, very significant tumor burden, like a lot of lymphadenopathy, sometimes you can, before giving like the full dose chemotherapy, you can give like softer regimens of chemotherapy. For example, if this patient has lymphoma, like you can start with like some doses of pure steroids to shrink the tumor before you actually start the regimen. So that's another thing that you can do to kind of like prevent having, full-blown TLS in the patient. And it is possible to cause TLS with just steroids, by the way, if in a tumor that is extremely responsive. So, but that's another thing that you can do. And so diagnosis, after going through all of this, like basically it requires 2 or more of the following lab abnormalities. So hyperuricemia over 8, hyperkalemia over 6, hyperphosphatemia over 4.5, and hypocalcemia less than 7. And this is, of course, like it has to be time related with the patient getting chemotherapy. I think the official stat is something like 3 days before, 7 days after starting chemotherapy for well, of course, cancer. And then it also requires at least one of the following, acute renal failure, cardiac arrhythmia, like we mentioned, or seizures. So these are, of course, the clinical presentations and why it's important to treat TLS. And going a little bit more over like the pre-treatment, like we discussed. So you give intravenous fluids with goal urine output of approximately 2 cc's per kg per hour. If you're adequately hydrating the patient and the patient is not urinating enough, you can consider giving Lysis to help you get to that urine output. Then you can give uric acid reducing drugs if necessary. We went over a few of the options and send testing for G6PD deficiency. It's a rasburicase contraindication. Another contraindication is pregnancy. I know we don't see it a lot in patients, especially like who are about to be given chemo, but it's something to think about. And then, okay, so this is another case, still the same condition, but while on call in the lymphoma service, you receive a patient regarding follow-up labs for a patient that you're cross-covering. He's a 60-year-old male hospitalized for the treatment of DLBCL, and the patient was just started therapy with rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. So, a good amount of chemo. And then you notice that the entrance note mentions in the morning that they were about to start allopurinol and IVF, but forgot to put in orders. And when compared to the AM labs, the K went from 5.5 to 6.8, uric acid went from 7.1 to 10.5, phos went from 3.8 to 4.6, calcium went down from 8 to 6.8, creatinine went up from 1.1 to 3.5, and additionally, the patient refers that he has not urinated since the morning. So how do you manage this patient? What would you start thinking of? You're the intern on call and you see this case. Let me see the chat. EKG, bladder scan. Okay, good thoughts, Emily. Definitely would start IVS. Raj, I agree. Lassie, I assume you mean Lasix. Yes. Definitely. Raj, very good. You call a screen. Why would you call a screen, Raj?
You know, that's a pretty rapid change in a lot of electrolytes, specifically the K. Also, you know, developed acute kidney injury in a matter of hours. So before this gets any worse, I would want to have the input of someone that could help manage and probably get labs around the clock for this patient. And that probably needs an ICU level kind of care.
Perfect, Raj. Great all around. Speaking of getting help from or getting people involved, would you want to consult someone else?
Nephrology.
Yeah, definitely. And Nadeem mentioned patient might need dialysis in the future. Emily also mentioned renal. So yes, basically some of the things that this patient needs, first of all, again, we didn't mention, or we kind of mentioned with Emily, the EKG. You would definitely need to treat the hyperkalemia again right away. You might want to start thinking about like treating the uric acid, but like definitely getting the fluids and things that have to be monitored in the ICU. Of course, if this patient has this electrolyte disbalance, we want to make sure that the patient has no cardiac arrhythmias. Definitely something that would be monitored in the ICU setting. Like we said, Raj talked about, you know, this patient might need labs around the clock. We'll talk a little bit more about the frequency of the labs, but if the patient has TLS, you need labs every 4 to 6 hours. So if you do that to a nurse on the floors, I'm sure you'll hear about it if you put the order in. And what else? So we talked about that. We talked about another thing, like you're gonna want to measure the hourly urine output, right, to see where you're trending. That's not something that can be like reasonably done on the floors. I would definitely be worried about like what Nadeem said, this patient eventually developing organ failure, cardiac arrhythmias, you know, requiring dialysis even. So very good. That's kind of like where my mind would go towards. So great job, everyone. And this is kind of a bigger like picture kind of slide where I tried to summarize the management of TLS. And I figured it made sense to me to divide it just by the criteria, like the different lab values that you have. So you have hyperuricemia that can cause arthralgias, AMS, AKI. So options really like respiratory, allopurinol, hemodialysis would be your last resort. But if you have no urine output, you know, and you already have renal failure, that might have to be that might have to be your own option. And you have to, you know, ensure adequate hydration to avoid crystal precipitation. For hyperkalemia, you want to, you know, this causes muscle weakness, cardiac arrhythmias. So we talked a little bit about like some of the options, you know, insulin, albuterol, calcium, hemodialysis would be last resort. We mentioned loop diuretics and glaucoma, and you definitely want telemetry monitoring for that. Now, hyperphosphatemia, it can also cause nephrocalcinosis, cardiac arrhythmias because of the calcium phosphate deposition. But that's a little bit harder to treat actually. That like, you know, you would basically give a low phosphate diet, maybe like phosphate binders, adequate hydration since it's also renally cleared. And if you're having trouble controlling this and you know, it gets to dangerous levels, you might have to use hemodialysis again as a last resort. Hypocalcemia can cause neuromuscular irritability, cardiac arrhythmia, seizures. So you need to manage that hyperphosphatemia, and yeah, you can give calcium gluconate. How much? Sorry, I see something in the chat. Oh, Nadim, I thank you for that comment. I'm glad you liked it. But so how much calcium would you give if a patient, let's say, starts having, muscular irritability? You're giving it for hypocalcemia, not hyperkalemia. Does anyone know? Would you, let's say, give enough calcium to bring the serum calcium above 7? And what would you be worried about if you started giving that much calcium? And that's kind of what I'm hinting at. And it's the first point in the management of hypocalcemia. So basically, you're worried about calcium phosphate, right? Precipitation. If the patient has very hyperphosphatemia and you just start giving calcium, you're worried about causing further injury from crystallization. So you basically just give enough for symptom resolution. And then the management is controlling the hyperphosphatemia, controlling the TLS. That should be the main goal, because like I said, this is kind of like an indirect effect. And we talked about general measures, especially in renal impairment labs every 4 to 6 hours. If the patient has, a high risk of TLS, not full-blown TLS, I would say every 6 to 8 hours. If there's a moderate risk of TLS, I would say every 8 to 12 hours. But you have to monitor the labs frequently. And basically, yeah, consider ICU care, especially when you have clinical TLS, not just risk. And, take home points, what you need to know about TLS as an intern, know the risk factors, because you're probably going to be the frontline provider recognizing the risk factors for this patient. Minimize the risk before therapy. Look for it in the labs, get labs frequently, like Raj mentioned. And, treat accordingly and know when to escalate care. At the end of the day, like I said, you're not going to be treating this by yourselves. You're going to have a very comprehensive cancer team, hopefully, and a team of consultants helping you deal with this. So recognize it and escalate it when it's important for the patient. Okay, so we're changing the topic a little bit. And so now you're in the ED at Mount Sinai West, because we also work here, and you see a 62-year-old female with past medical history of metastatic breast cancer who is presenting with 2 weeks of mid-back pain, worsening bilateral lower extremity numbness and weakness for the past 4 days. Upon physical exam, the patient has tenderness in the mid-thoracic spine and bilateral lower extremity weakness with hyperreflexia and diminished sensation. Which onc emergency are you worried about and why? So yes, everyone is getting it. So core compression, metastatic red flags, bilateral weakness. Okay. So yeah, so why are you worried about it, or what in the presentation is making you think about cord compression for metastases?
So first of all, the risk factor, meaning metastatic breast cancer by itself. Second, the acuity of everything. And then also just the neurological exam, just hyperreflexia, diminished sensation, just upper motor symptoms.
Yeah, no, I think it's great. If you have a history of cancer and you have back pain by itself, which is by itself the most common presenting symptom, you have to start thinking about does this patient have spinal metastasis, right? And so here you have back pain. You also have so Lenise is saying metastases, yes, osteolytic lesions to the spine definitely make it concerning, especially if you already know they're there. Sometimes the patient will not come with just a past medical history of metastatic brain cancer, but you'll know they have spinal mets. And now, later on, they develop the neurological symptoms, right? Maybe initially it's just spinal metastasis, and now it's compression. So you have to be able to detect that change. So yes, Lenise, it can be part of the history as well. And so, yes, here you have tenderness, you have hyperreflexia, and diminished sensation. So these sensory motor symptoms definitely should raise your suspicion for malignant spinal cord compression, sky high. So which imaging study would you choose as a diagnostic workup? I'm going to use a poll for this. Just give me a second. So there we go. Would you choose a CT myelogram, MRI with contrast, MRI without contrast, or a CT non-contrast? So I'm going to give it a little bit more. We're pretty satisfied with the results. So I guess over half of you have answered choose now or never. 5, 4, 3, 2, 1. There we go. Okay. So I'm just going to show you the results a little bit. Most of you chose the MRI with contrast, and that is a correct choice. A few of you thought MR without contrast. So it's important to have contrast to be able to actually visualize the spinal cord compression. That being said, if the patient has a contraindication to contrast, you can still do an MR without contrast, and it's still pretty good at detecting spinal cord compression. So definitely don't think like, oh, I can't get an MRI just because I can't get contrast. No, that would still be a good choice. And if you have a contraindication to MRI, then CT myelogram would definitely be a good choice. Suboptimal, but still, an option. And basically because, the CT scan is very good at detecting compression fractures, bone involvement, but it won't really be as good at telling you, that spinal cord involvement, especially the CT non-contrast. Now, another question, a little bit more detail. So we mentioned this patient had thoracic tenderness, right? Bilateral lower extremity weakness. How would you order your MRI with contrast? Would you get cervical, lumbar, thoracic? And you can put it in the chat. You can unmute yourselves and we can go over that. So Joe, perfect, whole spine. And the reason why it's like up to a third of patients, like even though you only have like a limited presentation, or you might have only tenderness in one area or specific sensory motor involvement, about a third of the patients have involvement in other parts of the spine that might not be detected yet. So once you're thinking, this patient might have spinal cord compression, you really should be doing the whole spine. So thank you for that. Now, basically, this is just the standard definition of like the spinal cord compression. So it's basically, encasement and compression that surrounds the spinal cord or cauda equina, in this case by cancer, right? So that's malignant spinal cord compression. And what is the emergency? Why is it important? It requires early detection and treatment to relieve pain and preserve function. And it can be an initial manifestation of malignancy. I forgot the exact percent, but yeah, about like 20% of like the patients with some of the most common types of cancers causing spinal cord compression can present with just like back pain. So definitely something that you need to consider, and you always need to keep it in as a potential differential. So going over, I mentioned, some of these tumors are a little bit more likely to cause it than others. So breast, prostate, and lung cancer are the most common ones. They're also, some of the most common forms of cancer. But yes, usually these type of solid tumors cause a very significant amount of the cases of spinal cord compression. And that's why in our particular case, with a past medical history of breast cancer, that should start, turning your gears a little bit towards that. But you also have some other types of cancers. You have lymphomas, you have renal cell carcinoma and myeloma that can also present it as well. I think, yeah, it was like about 15% of the cases were caused by these 3 tumors. So definitely can present with other types of cancers. In terms of location, so thoracic is the most common one. It's 60%, and that's why our patient had thoracic tenderness. But also about 30% are lumbosacral and 10% are cervical. Again, this is gonna potentially give you different presentations. And talking about presentation, so back pain is the most common symptom, like I mentioned, and it can precede neurosymptoms by weeks to months. It is usually worse when supine, or it can also worsen by with Valsalva maneuvers. This is a type of pain that is strong, and it can awaken the patients at night. And it can also cause referred pain. So if you have cervical compression, you can actually have subscapular pain. If you have thoracic compression, you can have lumbosacral or hip pain. And if you have lumbosacral involvement, you can actually have referred thoracic pain. So that's also something to consider, and part of why a full spine MRI is also important, because they will not always be, so cut and clear in their presentation. Some of the neurologic manifestation, we went over them. So you have motor weakness, sensory impairment, autonomic dysfunction, meaning, usually bladder dysfunction is what they present with. And you might have lower motor neuron findings, usually asymmetric. And upper motor neurons are usually symmetric, but that is not, a clear rule. You can have patients like our patient in the case that presented bilaterally, and you can have upper involvement that presents unilaterally. In the physical exam, so you have tenderness to palpation or percussion. You can have hyperreflexia initially. So yes, I did mention it there, that later reflexes can become absent. You can have spasticity, loss of sensation, and this is position, temperature, pinprick, vibratory. Babinski sign, decreased tone, sphincter tone are usually late signs. So workup, like I said, cancer patients with back pain and normal neuro exam should still have imaging within the next 2 to 3 hours, because you don't know if this patient is at risk of spinal cord compression or is having some degree of compression, and will later develop worsening symptoms. Usually patients have back pain for about a couple of weeks, and then once they start developing neurologic symptoms, the progression is a lot faster than that afterwards. Neurologic manifestations, of course, require emergent evaluation and treatment, and otherwise it wouldn't be in the Heme emergencies curriculum. And whole spine MRI is the gold standard if contraindicated, like we talked about. It's CT myelography, and you really shouldn't be ordering only X-rays to evaluate for spinal cord compression, because they have a high false negative rate. And I forgot to mention as well in the why is it important to detect this early on. One of the main predictive factors of the neurological recovery for patients with spinal cord compression is the neurological status before they develop the spinal cord compression, or before you made the intervention, which means that the more you let it develop, the more the function worsens before you intervene, then the worse the prognosis is. So the faster you act, then the better chance the patient has of neurological recovery. So this is the same case. Let me see, or yeah, I think so. So she has pain to palpation in the thoracic region, a hyperactive knee. It's slightly different, but so it's a 62-year-old female, also at West, past medical history of metastatic breast cancer, presenting with, like we said, 2 weeks of mid-back pain, worsening bilateral lower extremity numbness and weakness for the past 4 days. Like we said, initially, for a couple of weeks, you'll have pain, and then the neurologic presentation, once it's there, it kind of goes a little bit faster. She has pain to palpation in the thoracic region, hyperactive ankle and knee reflexes. You order the MRI, you see a large lytic lesion and T7 causing compression of the spinal canal. And then patient refers good functional status before this episode. After discussing with her oncologist, this patient has an expected survival of approximately 6 months. So this is another important part of identifying spinal cord compression and spinal cord involvement. Once it's there, prognosis is generally poor, and it's actually a median of about 6 months. So I'm sure, just judging by the answer of the imaging workup, I'm sure most of you know that like you have to give IV dexamethasone as acute treatment of malignant spinal cord compression. Now, besides that, what would be the appropriate course of therapy for our patient? And let me yeah, accidentally. There we go. So now you should be able to use it. Which of these choices would you do? And some of these questions, like, or all the questions, I kind of like base them on MEXEP. So yeah, don't think I'm not intentionally trying to be mean with you guys or trying to trick you. Okay, 40% participation. Let's see if we can get a few more. Okay, so I'm gonna give you 10 more seconds. So do it now, it's anonymous. Okay, now we reached 50%. I'm gonna end the poll. I'm gonna share the results. So we kind of had like definitely a much more split opinion in terms of what to do. So actually the correct answer for this question would be immediate decompressive surgery. And so talking a little bit about why, when it comes to treating malignant spinal cord compression, you of course have to consider many different things. One of them is how bad is the neurologic presentation that might affect some things, going from like the steroid dosing. You might use higher doses if the effect is a lot more significant. In terms of elective radiation, like we said, this is an emergency, so that would not like necessarily be the correct choice. In terms of urgent radiation, so that is an option that could be reasonable if it's a tumor, like let's say like lymphomas or something that is going to be very, very, very responsive to radiation. Otherwise, what it would do, it's like only delay the management, which in this case is breast cancer tumor there that needs decompressive surgery. Not only that, but there's been trials that have shown that the combined use of both surgery and radiation actually leads to a better, preservation of neurological function, a better even survival, despite it being like kind of you're talking about days or a month. There is a difference in survival when you use both, and patients also, retain their ambulation for longer if you do like that combined surgery, surgical versus and radiation approach. In terms of palliative care only. So, of course, this wouldn't be the wrong choice if that is what the patient desires. And that's, after you discuss the risks and benefits of the intervention that the patient does not want to participate in. And for the most part, you think about a lifespan or a prognosis of less than 3 months. That would be the point where you start thinking like, oh, this patient might benefit from like just palliative care only, or might not benefit as much from immediate decompressive surgery. If the patient had no contraindications for surgery, had a good functional status, besides, the cancer, of course, like no significant other comorbidities, before they presented with a spinal cord compression, you can still consider, decompressive surgery, even if they only have like 5 months of prognosis. So that's kind of like where you would kind of draw the line. So palliative care only, not necessarily a wrong choice, but like I said, it depends on the patient, and you really have to let them know that, they're like, especially if the prognosis is greater than 3 months, that their symptoms are gonna get worse. They're gonna lose, the ability to walk potentially. They're gonna lose bladder function. They're gonna have all these other symptoms that will affect their quality of life, their remaining quality of life. So that's something to consider. And So now I went a little bit over, like that question was intended to go a bit over the management of spinal cord compression. So like I said, I tried to summarize everything in a table again. This time, I wanted you guys to just to visualize that this is a problem that has different moving pieces. It's not just pain and the neurofunction. So for management with the problem of compression, meaning kind of like the neurological presentation, you need treatment with steroids, radiotherapy, surgery. Like I said, it's gonna depend, sometimes you could even use chemotherapy if you know that the tumor is like extremely responsive to it. So that's something that like will depend on the type of the tumor, the location of the tumor, and also, I forgot. So yeah, I included it there. So surgery, if vertebral instability, neurosymptoms, it depends on the prognosis, like we mentioned. So there's a score actually that you can look up, and it will tell you like if they're a candidate for surgery, even based only on like vertebral instability. That's definitely something that's not going to get fixed with just like radiotherapy. I mentioned lymphoma, myeloma, seminoma, highly responsible to radiotherapy. Beware of steroid side effects. So dexamethasone, it's actually hasn't been fully defined to the adequate dosage that you're supposed to use. But it was found that dex at 10 milligrams IV times 1, then 4 milligrams Q6 can be, as good as like other higher doses they were using. I think it was 80 or 90 that then gave like stress ulcer and other side effects. But if the neurological presentation is really bad, it's something that can be considered because again, it's not completely defined in the guidelines, the dose. And just be very careful if you have suspicion for lymphoma, because you need a biopsy for diagnosis. And if, like we mentioned before in TLS, lymphoma is very responsive to steroids. If you give it, you might, treat the lymphoma before being able to get a biopsy, and that can be a problem. For pain, you can use all those agents that I put there: opiates, scatolone, pregabalin, tricyclic, TCAs, bisphosphonates, Tylenol, NSAIDs. Definitely all options to control the pain. You need to think about the mobility. So PT, OT, early ambulation decreases risk of immobilities. Psychosocial, of course, like I mentioned, this is a very grim prognostic indicator. So definitely start thinking about getting palliative care involved, even if you are actively treating the patient. And also, psych can be considered. It's not something that necessarily has to be done inpatient, but even though cancer makes patients sad, it's also true that depression is very prevalent in the cancer population, so something to consider. And of course, because of the presentation and the autonomic dysfunction, think about like treatment for incontinence or constipation, depending on the presentation, and also bladder control measures as well. And take-home points: work up all cancer patients with new back pain. All early intervention is crucial. Like I said, it affects prognosis. It is a grim prognostic indicator. Like I said, address life expectancy and the patient's goals once you start having that. And that's it. I think we don't have a lot of time for questions. I'm going to hand it over to Sani, but all of you have my phone number. All of you have my email. If you want to just like curbside me and chat about this topic, or if you have any questions, feel free to reach out to me. I'm more than happy to do so. And I hope it was useful for you guys. Julia and I are working on a curriculum that we eventually want to upload to the page, to our webpage, hopefully. So hopefully this is useful.